There you go.
Welcome back, RLR, VMR, CP solvers. Today we have a special guest that hasn't been present for some time. Robbie, do you want to unmute yourself and just introduce yourself to the audience?
Are you encouraging me to talk? Oh my gosh. Wow, I'm honored, Prof. Rez. I don't know if you guys know the normal vibe. Normal vibe is I blabber away and Prof. Rez tries to get me to minimize my conversations. But yes, it's really nice to see you all. It's really nice to be back on VMR. It's like my return back to my normal life is to hang out with Prof. Rez and to hang out with you all. So I'm super excited for this hour.
Where were you, Robbie?
Folks, I was in Thailand with my wife. It was actually our 1 year anniversary, and we were celebrating by, I think, going to probably one of the most peace loving, mellow places I've ever heard of. It was just an unreal experience. I sent the CP Solvers Academy folks a lot of pictures, and Prof has a lot of pictures, but I think what you can't quite capture is um, just how gentle everybody is and how happy everybody is. It was really kind of a surreal experience to come back to the US where everybody, even in the West Coast, everybody's like hustling and moving fast and whatnot. And in Thailand, it's just all about gentleness. So, yeah, it was an unreal experience.
Hey, Robbie, leave some room for the case discussion, my friend. It's just formalities. You're too calm. I'm about to
By the
hustle and bustle.
way,
But I did have one more question for you. What was your favorite part of the trip?
my favorite part of the trip, honestly, was just talking with people. Like, my favorite part was that every interaction I had with like a local and seeing what they're like and how they vibe. Yeah. And there were like not many of them. There were only like 4 or 5 of those kinds of interactions. But yeah, those were the highlight.
Dude, I would have said the infinity pool that you were swimming in on a daily basis. Anyways, our case presenter, I want Himun to unmute yourself and please introduce yourself to the community.
Yes, hello, my name is Hee Moon. I'm an ING from Korea. After marrying an American husband, I came to Utah 4 years ago, and unfortunately I didn't get matched this season. I was a little bit disappointed myself, but everyday BMR people really motivates me and to love medicine. So even though I feel like I'm in dark right now, but I can go one step forward every day because of you guys. And I'm so glad to present case today.
Himun, that is so lovely. Thank you for sharing that. All of us have had barriers, but they're just that. And they really test how much you want to achieve your ultimate goal. And just to share with you, I didn't get into medical school the first time I applied, but look at me now on top of the world.
Right, you
I
are.
would say. Um, Thank you for joining us. My father actually lived in Korea in Seoul for 3 years. He loved it. He's a civil engineer, was working on an airport there.
That's great.
David, please unmute yourself. Tell us what you're doing today.
Hi everyone, I'm doing the teaching points. So, Skyrim, so sorry. So very happy to be here.
Thank you. Amol, please unmute yourself and say a few words.
Hello everyone, my name is Anmolpreet Kaur and I'm from Punjab, India, and I'll be doing the teaching points today. Thank you so much.
Thank you, Amol. All right, Himun, the microphone is yours. I hope the first aliquot is the most difficult of this case because Robbie is up.
Yes. Okay. I will start. The chief complaint is diffuse joint pain. A 60-year-old gentleman presents with a 1 month history of intermittent pain in asymmetric multiple joint, left knee, left wrist, both ankle, and several painful red bumps on the left leg for the past 2 weeks. Pain worsened at night and shows slight improvement with the NSAID. He had a similar kind of diffuse joint pain for 2 years ago, which was presumed to be osteoarthritis at the time, but he didn't have hip pain at the time. His pain has improved since then, but has never completely resolved. He denied joint stiffness in the morning, fever, chill, night sweat, weight loss, other rashes, oral ulcer, dry mouth, eye pain, eye tenderness, hematuria, diarrhea. These are all no, and no history of trauma. I will stop here.
Oh my gosh, this year this is clearly a seasoned presenter. Thank you so much for the clarity of the HPI, and I think you set us up to discuss two different aspects. The first is the joint aspects, and the second is the painful bumps on the leg. And Prof. Rez, maybe I can start off by just reflecting on the joint stuff, and then see how you can incorporate the skin stuff. And I think at first pass, we probably have to remain cautious not to do what I just did, which is to translate the words of "it hurts in my joints" to a joint problem. In many instances, patients refer to discomfort around their joints as a joint problem, but it could easily be a diffuse ligament problem, a diffuse tendon problem, or a diffuse bursal problem. But the truth is that the more and more joints are involved, and the more and more that patients hurt around several joints, the more likely it is to be truly an intra-articular problem. That's because a bursa or a ligament issue is a very plausible hypothesis when somebody has one quote unquote joint that is hurting, but it's fairly unusual and much more likely to have a multiple joint issue rather than a multiple bursa or tendon issue. And so I think it is a little bit of a leap to call this an arthropathy, but I think with the sheer number of joints involved, that's probably more probable. And as you've heard from medical training, we tend to try to divide joint issues into monoarthropathies, oligoarthropathies, and polyarthropathies. And the strict definition is that mono is one joint, poly is more than 8, and oligo is less than 8. Now, why is that distinction important? It's important because it profoundly influences the differential diagnosis. Oligoarthritis is the space that we're dealing with here because we have multiple joints, but they appear to be less than 8. Let's talk about that last. Monoarthropathy is often the result of osteoarthritis, but in the acute setting, developing over days to weeks, maybe crystalline or maybe infectious. Polyarthritis or arthropathy is almost always autoimmune. The exceptions to that are self-limited polyarthropathies, which tend to be viral infections like parvovirus or chikungunya. And so you can see how the landscape is very different in terms of causes of polyarthritis than it is of monoarthropathy. And the question is, well, what about oligoarthritis? What about when there's a few joints involved? Not one, but not more than 8. These cases tend to be the most diagnostically challenging because they actually have features of both monoarthritis and polyarthritis. One of the features common to monoarthritis is namely the crystalline arthropathy, gout, pseudo-gout. They often affect people with just one joint, but they can be with multiple different joints. That's what they have in common with monoarthritis. What do they have in common with polyarthritis? Autoimmune diseases. And the autoimmune diseases that present with oligoarthritis are often the spondyloarthropathy family: reactive arthritis, psoriatic arthritis, IBD-related arthritis, and ankylosing spondylitis. That's the most common space for oligoarthritis. Now, in each category, both mono, oligo, and poly, we have to think about infections. And the infections that tend to affect patients with oligoarthritis are disseminated gonococcal infections and septic arthritis, oligoarticular septic arthritis. So in summary, in all categories, mono, oligo, or poly, we have to think of infection. And within the world of oligoarthritis, the infections to entertain are bacteremia, causing polyarticular or oligoarticular septic arthritis, and then disseminated neisseria. What's unique about oligo? The crystalline diseases pop in from the mono category, and from the poly category, autoimmune diseases sneak in, but of a different variety, the spondyloarthropathies. That's the lay of the land that I think we're thinking about in this case from the arthritis perspective. Any thoughts on that, Prof. Rez? And I'm curious what you're making of the skin stuff and where that's going for you.
No, I really admire and love that approach. I thought that was a tour de force on all joint symptomatology. And I'm going to actually be brief in my discussion here because if I'm being authentic, when someone reports a rash, I think the best thing to do is to look at it because the morphology will really influence the differential diagnosis. But I'm just going to share two brief thoughts on like reflexively based on the description where my mind went. But we have to make sure to confirm this on the physical exam. And especially coupled with the joint pain that Robbie had mentioned. And when I hear painful red bumps on the lower extremity, my mind automatically goes to erythema nodosum and its differential diagnosis. Now, erythema nodosum is just a hypersensitivity reaction to an antigen. The first step is to make sure the patient isn't on any medications that might be responsible for it, like antibiotics. But you also have to consider the differential diagnosis for E. nodosum. And that differential diagnosis includes erythema induratum, which is not a hypersensitivity reaction, but is really a painful lesion that can be ulcerative, usually secondary to tuberculosis, but has various secondary causes and is on the posterior calf rather than the anterior. So I'm going to be very interested when we get to the exam and Hemoon tells us about it, whether it's the anterior, like the pretibias where E. nodosum loves to hang. But there's other etiologies where you can actually have mycobacterial infection, fungal infection that can infiltrate the skin, giving the appearance of E. nodosum. Now, this isn't a hypersensitivity reaction. This is actually the infection is infiltrating. And you can imagine if this patient has a mycobacterial infection or some other form, it can involve the joints and the skin. And thirdly, in my differential diagnosis is cancer. So you can have leukemic cutis that can also cause painful lesions. But what if we got to the physical exam and there's just like a bump and the patient hit their leg against something? Or the patient just had like an insect bite or something? Anyways, I think the best approach to rash is to look at the rash. And then based on that, you can start making assumptions and try to incorporate it with the presenting complaint of joint pain. Robbie, do you take a similar approach or anything else?
100% proper. I couldn't agree more. Nothing.
Mike, to you, Himu.
Okay. Yeah, the rash really looked like erythema nodosum, though. Yeah. Okay. Past medical history, not significant. He has hypertension, medication, NSAID, amlodipine for hypertension. Family history, no autoimmune, psoriasis or rheumatoid arthritis, IBD, no. Uncle had a factor V latent deficiency, so he had like DVT or pulmonary embolism. But I asked him, my patient, and he denied DVT or pulmonary embolism in the past. Social history, heavy alcohol use for many years. He traveled to Thailand on multiple occasions because his girlfriend lives there. Should I keep going or stop here?
Maybe keep going, Himu.
Okay.
Thank you.
All right. So the physical examination, vital signs is febrile and heart rate is 78, BP is 150/90, respiratory rate is 15, and saturation is 99%. And eye exam, so those exams are really in detail. So I want to look at the uveitis. So I was looking for redness, tenderness, irregularity in pupil shape, or constriction to light, and everything was normal. No conjunctival scleral injection. And mouse, no oral ulcer, and no cervical lymphadenopathy. Cardio, no murmur, palpable peripheral pulse, pulmonary clear to auscultation. Abdominal, GI, no tenderness, no hepatosplenomegaly, no more bowel sound. Neuro, strength and sensation is intact, no peripheral neuropathy. Extremity and skin, swollen and erythematous left knee with a reduced range of motion, and both ankle and left wrist joint is mildly swollen and erythematous, but the range of motion was okay. Tender and erythematous subcutaneous nodule up to 25 millimeter in diameter over pretibial, malleolar, furular region with the ill-defined borders. And hand is no deformity, no dactylitis, swan neck or ulnar deviation, no nail pitting, because we are considering about psoriasis too. So, and then for the axial joint mobility, lateral lumbar flexion test over 10 centimeters showing normal, and no other rash observed. We did it from head to toe, including the scalp and the gluteal cleft, and everything was normal. He only had rashes on his left knee. That's it.
Such
I
a
will stop
detailed,
here.
such a detailed exam and super helpful. And maybe, Robin, we can just continue along our lines of reasoning. I'll leave the joint stuff for you, and I'll focus on the skin stuff. And I think as far as the other data, like social history, there's not too much weight I'm putting on that just yet, but maybe later it might become relevant. And I think it was really helpful that Hee-moon told us that the rash appeared like inodosa. And so the question becomes, we listed that differential diagnosis for erythema nodosum. When do we need to biopsy inodosa? And let me give you a glass bead. So in the US, in English, we say pearl when it's something really meaningful, but when it's not a pearl, we call it a glass bead. And the glass bead is this. If you have someone with like palpable purpura, you don't need to biopsy that on the lower extremities because it's probably going to be leukocytoclastic vasculitis. So the biopsy doesn't necessarily change the DDX. With enodosum, it's very similar. Like if it's characteristic of enodosum, you don't need to biopsy it because you'll get what's referred to as paniculitis, because this hypersensitivity reaction is occurring in that subcutaneous fat layer. But it's good to know when should you biopsy it. And I'm referring to my notes here, and I have 3 scenarios that you should biopsy it. One of them, if it's including sites other than the legs. So if you have it on the arms, because that's just not characteristic. To use analogical reasoning, Hee-moon told us the patient was diagnosed with osteoarthritis but didn't have hip pain, because hip pain is so classic part. It's a weight-bearing joint. So this, if it weren't on the leg, we'd have to be like, wait, that's not usual for enodosum. Another reason to biopsy is if you get associated ulceration, because enodosum isn't a problem with the vessel, and you have nodular vasculitis as a mimicker, but that's when you actually have issues with the vessel, and then you have ischemia and then ulceration, you have to biopsy it. Or if it persists beyond 8 weeks, because most causes of enodosum, hypersensitivity reaction, they're transient in nature. Usually we don't have that third component, but we can tell by this patient, it's on the legs and there's no ulcers. So this patient doesn't necessarily need a biopsy. Now, you may consult dermatology, they may do a biopsy, but I'm assuming it's going to be paniculitis. So now I'm ready to actually think about erythema nodosum. We already talked about the pathophysiology, and I have a 2-step approach to enodosum. Step 1 is review the medications and see, are any of the medications a common culprit? But here, my friends, I wouldn't, let's say this patient was on Bactrim. Why wouldn't I blame it on the Bactrim? Because you have another problem in this patient. It's not just isolated enodosum. You have to go extracutaneous you have extracutaneous manifestations. So it's not medications. And I wouldn't chalk it up to idiopathic. I would really seek a diagnosis. And here we would just activate the IMAID mnemonic with a focus on infection and autoimmune and less commonly malignancy. And we have I'm sure Robbie has probably like an amazing graphic represent. Robbie, you do, huh? A schema for enodosum with the beautiful buckets on your Evernote.
Maybe
Do you
not.
mind bringing that up and taking over and then jumping into and maybe incorporate the joint stuff and see if you can link it? Thanks, thank you.
Yeah, you got it. Proper as I just love I love the prediction of the biopsy, the confidence that this is enodosum to the point where you know what the biopsy is going to show. And I completely agree with you. I think it's also really cool to see the really powerful distillation that this is not just enodosum. This is a paniculitis with arthritis, and I think that's not common, right? It's a pretty unusual combination. But if we just go back to first analyzing the arthritis separately and then try to link it into the enodosum, I think the first thing that happened is we got confirmation that this is really an oligoarthritis. The oligo has been confirmed by the less than number of 8, and the arthritis has been confirmed by HeMoon's outstanding physical exam, which, by the way, goes above and beyond the basic arthritis exam, and I'll try to explain that next. But if we're sticking back to what we learned about oligoarthritis and now in less detail and more broad strokes, oligoarthritis is all about, is it crystalline or is it autoimmune fundamentally? And I say that OA is unlikely here because of the joints that are involved. Ankle osteoarthritis and wrist osteoarthritis are exceedingly rare. Infections here, namely pyogenic bacterial infections from bacteremia or disseminated Neisseria, are highly unlikely in this otherwise well-appearing patient. So we're only really considering 2 categories. Is this crystalline disease or is this autoimmune? And so the question is, where do we lean? Remember that all the autoimmune diseases that cause oligoarthritis are of the spondyloarthropathy family. And that's where HeMoon's outstanding exam helps dramatically reduce the probability of these considerations. She specifically told us about the lateral flexion test to help us assess the possibility of spondyloarthropathy. And the fact that that is negative dramatically reduces the probability of this condition. The fact that he has no other rashes reduces the probability of reactive arthritis and psoriatic arthritis. And she went above and beyond even to examine an area that's hard to visualize, which is the gluteal cleft, a sneaky place where you could have psoriatic plaques. So you can see here, this is a very targeted, hypothesis-driven, outstanding exam that dramatically reduces the probability of a spondyloarthropathy. Now, the problem with ankylosing spondylitis is it really is a sneaky condition that has often no other manifestations apart from the back. But one thing that I think was so cool to see HeMoon specifically emphasize is, you may be wondering, why was she telling us about the eye? And she was telling us about the eyes because of the possibility of subclinical active uveitis or active evidence of prior uveal inflammation. Again, a superb attention to detail in that respect. So I think if we have the 4 categories of oligoarthritis in front of us again, infection, less likely because this is not a hectic case. OA, less likely because it doesn't affect the wrists and ankles in most circumstances. And then finally, spondyloarthritis, less likely because of the absence of uveitis, rash, and consequences of longstanding arthritis on the spinal mobility. So is this a crystalline issue? And in order to understand crystalline issues, I think now is the time where Prof. says we put a pin in the social history. Now is the time you have to come back to the social history, because the social history is really, really key here. Anytime that you have alcohol use and you're wondering about crystalline arthritis, it dramatically increases the probability of gout. Now, could this be gout? And the question is, could gout cause oligoarthritis? The answer is yes. Could gout cause a paniculitis? And the answer is absolutely yes. In fact, I've seen gout cause paniculitis maybe 2 or 3 times a year based on how frequently we see it. So I think, Prof. Rez, really by exclusion, we're zeroing in on crystalline diseases. And I think that you probably be leading in with prioritizing gout, given the association with alcohol use and given its ability to cause paniculitis. There's a major there's a major discrepancy though with gout, and that's the fact that we don't hear of anything involving podagra or involving the first MTP. And we also see that this arthritis is really lasting a lot longer than the monoarticular attacks of gout, which is leading me to start to wonder of any other crystalline diseases that are less common and potentially linked to alcohol use. And the answer is yes, there are some, but I think it's too rare to start to invoke them now. So Prof. Rez, I'm locked in on crystalline, not locked in, but I'm really leaning into crystalline. But there's some unusual features here that have me wondering, is it really crystalline or is it something else? Or is it an unusual crystal that we don't necessarily think about immediately, but may have to entertain should analysis for gout beginning with x-rays and uric acid not be productive? Where's your head at?
I love it. I'm very interested to see more data and see where the case takes us.
Okay. All right. So the lab, CBC was normal. I was wondering about the chronic inflammation. So anemia will be seen, but there was no anemia. BNP was normal. Liver function AST, 170. Bilirubin and alkaline phosphatase was normal. We were considering about autoimmune, so ANA was negative. Rheumatoid arthritis, RFCP, negative. And also because of the erythema nodosum, we were considering about vasculitis. So ANCA was done but negative. And alpha-1 antitrypsin deficiency was also can cause erythema nodosum in the beginning. So we did that, but it was negative. IgG4 negative. Reactive arthritis we were considering because he was visiting Thailand so many times. So HIV, hepatitis B, hepatitis C, TB, gonorrhea, chlamydia, syphilis was negative. And one of my team member also want to do the C3, C4 for cryoglobulinemia, and it was negative. CRP was 153. I will stop here.
Oh, I'm so intrigued, Ewan. This is really a very, very interesting case. I think that you've shown us, really shown us the utility of the laboratory workup to really try to frame this case, and that it is inflammatory with the highest CRP, but it is not hectically so with the lack of anemia of chronic disease, the lack of thrombocytosis. And I appreciate the progress that we're making. I think we're making atypical presentations of collagen vascular diseases like the ANA positive diseases or the RF positive diseases less likely. And I think the laboratory workup largely has been helpful in excluding an unusual manifestation of something prominent. I do think that there is a really interesting lab that you could get here, but I think it starts to get in the weeds. So I'll hold that thought for now and see what Prof. Rez is thinking, and then maybe share that in a second. Where's your head at, Prof. Rez?
Yeah, it's interesting. I don't see as much gout as you do, Robbie. And I read the review article in NAGEM on gout. We dive deeply into this topic.
Yeah.
And
by we, you mean you. Prof. Rez is officially the world's gout master, I would say by now.
It's like I never had gout as a cause of E. nodosum personally. Like I didn't like that's like actually a new knowledge bit for me. And I wonder how common it seems like it's common in your practice, but they didn't really mention either they mentioned it, I just overlooked it. But regardless, so my mind went to other places. And I love your idea that probably infection is less likely for all the reasons you mentioned, even atypical infections, though not completely excluded. But my mind went to also the autoimmune category, specifically thinking about sarcoidosis, which is a diagnosis of exclusion. So I thought about sarcoid, and I thought about other granulomatous processes, including atypical infections. So for this patient,
Hmm.
I think it would be important to at least get a chest X-ray to see if there's hilar-adenopathy. Sarcoid isn't usually like an inflammatory disease unless it's Lofgren's, which comes with ankle arthritis, enodosum, and bilateral hilar-adenopathy, at which point you actually don't need any biopsy. You can actually diagnose it based on that triad and initiate treatment. And those patients tend to be inflamed. So I'm torn, and this is more because my lack of knowledge that panniculitis is commonly associated with gout. But regardless, I would get a chest X-ray, and yeah, and if for the reasons you mentioned, because it didn't involve the big toe, it's like I would get an arthrocentesis to confirm, like if this is truly crystalline. I just yeah, but I would love for you to reflect on that, my friend.
I completely agree with you, Prof. Rez. I think the only reason to entertain gout is not because this presentation is classic for it, but because it's so overwhelmingly common that an uncommon manifestation of it, namely panniculitis. So, I mean, Prof. Rez, I see like 3 cases of gout a day, and I've only seen gout panniculitis 3 times a year, probably. Those should show you how it is pretty unusual, but it's just so overwhelmingly more common. Um, I will share that I completely agree that we have to step back and entertain maybe a secondary layer of autoimmune disease like sarcoidosis. I think that's very wise, probably driven more so. It seems like you're being driven more so by the panniculitis than the arthritis, but then sarcoid causing arthritis is very wise. I feel like probably because of the bias of initially focusing on the arthritis, my mind is coming at this case from the arthritis case and seeing how we can incorporate the panniculitis. And that's in large part by a pattern recognition here. And that pattern recognition is incorporating a syndrome called PPP, pancreatitis, polyarthritis, and panniculitis. Now, the polyarthritis and the panniculitis are evident here, but the pancreatitis obviously isn't. But the pancreatitis might link in here with the patient's alcohol use. And that's, I think, where we're at, Professor, where we're like, are we dealing with the second tier of autoimmune diseases, not the spondyloarthropathies, but rather granulomatous autoimmune diseases like sarcoid? Or are we dealing with a second tier of crystalline diseases, not the common ones, but unusual ones? And so I just want to show you a visual just to show you how complex the crystalline diseases can be. And the reason we don't think about them so much is the 2 common ones, gout and pseudogout, are ridiculously common. But there are other crystals, basic calcium phosphate crystals, steroid crystals, fluoride crystals, oxalate crystals. These are all affect the joints. And then PPP. Pancreatitis, polyarthritis, panniculitis syndrome is super rare, but it almost exclusively occurs in patients with significant alcohol use. And the reason I'm saying that now is not because I think it's probable, but because a simple test, namely the serum lipase, can help you assuage before you go on a multi-million-dollar workup in the United States. An elevated lipase is very common in these patients, and they often have asymptomatic elevation in their lipase. They don't feel it in their belly for some reason. And so I probably think about adding that on and sending that. And if that is negative, I think that I would be open to an unusual manifestation of gout because it's so common, but move very strongly towards that second tier of autoimmune diseases that you mentioned. Alrighty, Eamon, back to you.
Okay, amazing discussion. I'm learning so much. Yeah, okay, I'll start it. Okay, so chest X-ray and urinalysis was done. It was normal. Knee X-ray revealed degenerative change, joint space narrowing, and wrist and ankle X-ray was normal. We did a aspiration, the synovial fluid analysis, showing the yellow cloudy color, thick viscosity. WBC count was 10,000. PMN was 50%. No crystal, no bacteria. Skin biopsy was taken, and I will tell you the result later. He was treated with NSAID and corticosteroid for multiple joint. 1 week later, with no improvement, our team considered maybe MRI to look for other cause of the bone pain, and However, at this time, he present with another complaint. It was mild, diffuse abdominal pain without radiation, nausea, vomiting, or fever. I will stop here.
So Heemoon, this is fantastic. And I think that ruling out hilar adenopathy was important.
Mhm.
I think aspirating the joint was critical because you want to make sure it's the first time presentation and you want to sample it and make sure there isn't crystalline disease. The lack of crystals you always have to be cautious with because it's not easy to see crystals, but I think the presentation is odd enough for crystalline disease that it almost, I think, like excludes that possibility. And I'm really glad, Robbie, that you mentioned the triple Ps, because I read that in the New England Journal of Medicine article. We're in this area of esoteria that's not common, but sometimes it's not common because we just don't know about this diagnosis. But there was a really good NEJM case, and literally the person just started listing each of the problems. They're like, there's pancreatitis, there is paniculitis, and there is polyarthritis. So I like the idea of sending that lipase and potentially arriving at this diagnosis. But I will say that you should never lead your DDX with such a rare entity. And you have to first consider common diseases, whether it's atypical manifestations of common diseases and ruling out more dangerous stuff like infection, like, a disseminated mycobacterial or fungal infection. I don't know the treatment or how you manage that condition of triple P, but what I do know is my job is to make sure there is an infection. That joint does not look infected. And there's no signs of your mycobacterial fungal on your chest x-ray, which is usually the entry point for these infections. So I'm pretty comfortable saying this is unlikely to be driven by an infection. I can't think of any cancer that does this. And the autoimmune stuff, you sent the RF, you sent other etiologies. So then you're left with this rare diagnosis, which I don't have an illness script for, but I remember seeing it in New England Journal of Medicine. Thoughts, Robbie?
Professor, I really appreciate you anchoring us in the reality of what it would be like to take care of this patient. I think you just have to be very careful not to get carried away when something is unusual about your case and to anchor it in your job. Your job is to first rule out morbidity and then accept reality. Accepting reality involves accepting that an unusual manifestation of something common here, and that's what we did. We're like, this is gout until proven otherwise. And the more and more we've proven otherwise, the more and more we're invoking something rare. And I think the other practical lesson here that Eamon is teaching us is the visualization of fluid. I think in internal medicine, we don't emphasize enough how important it is to describe the fluid that you just removed from the patient's body. And I think proceduralists are actually very savvy at saying, hey, this is chyle, this is bile, this is pus, this is blood. And I think when you tap joints frequently and you see yellow come out, you know you're dealing with something very unusual. Because I have never, ever, ever, ever in my life seen yellow fluid come out of the joint. And so I think the moment that you aspirate this patient's fluid and you see that stuff come out is the moment you know you've stumbled on the diagnostic clue. And I bet a simple Google ChatGPT search of yellow synovial fluid will probably get you the answer. That's how unusual it is. And I think if you didn't think of PPP before, I think it's important to think about it now. And what's essentially fundamentally happening is that the lipase is breaking down fat. It's breaking down the fat, causing the paniculitis, and it's reminding us that there's a lot of adipose tissue in and around the joints, cushioning the joints and softening the motion of the joints. And when those adipocytes are destroyed by lipase, you can get this very yellowy discharge and ultimately joint destruction. So it's really helpful that his abdominal pain now has emerged to help us think about the pancreas. I think it's really important to recognize that the pancreatitis label may be a little bit underselling the reasonable possibility that pancreatic cancer may be another trigger. So looking at his pancreas is important now for two reasons: to connect the final P but also to make sure that you're not sitting on chronic pancreatitis-induced pancreatic malignancy as the trigger for this. Anything else, Prof. Rez, before we pass the mic to you? Already, mic to you, my friend.
Okay. Right. Wow, you guys are so smart. Consider his heavy alcohol history. Yes, lipase and amyloid tests were ordered, revealing the lipase level skyrocketing 23,000, amylase of 1,000. Excuse me. CT scan showed pancreatitis with acute portal venous thrombosis extending to the splenic vein and superior mesenteric vein, and 1.4 centimeter pseudocyst was abute, the SMV, suggestion of a small fistula between the two, and the histopathology of dermatology revealed lobular panniculitis and neutrophilia and extensive fat necrosis. I will stop here.
Ki-moon, I have nothing else to add. I'll give the mic to Rob if he has anything to add.
I'm curious, what was it like? I just have a couple of reflections to share about just the practical learning in this case. But I'm really curious, what was it like for you to stumble into this really unusual diagnosis and to stumble into it the way you did?
Yes, so because he didn't really explain in the beginning, he didn't explain the mild, the abdominal pain, not really pancreatitis. So I was not thinking about that way at all. And I was researching, and it said elevated enzyme level does not really correlate with the severity of the pancreatitis. So yeah, that was a learning point that if patient has polyarthritis and panniculitis, always think about, even though it's really rare, this case is really rare, but think about the PPP syndrome. And the patient was managed with ERCP. Plastic stent was placed, and also for the fistula, the thrombosis was treated with anticoagulation, and his pancreatitis polyarthritis got really better, and lipase enzyme was normalized, and pancreatitis was really improved too. So you are right. The lipase enters systemic circulation through fistula between the pseudocyst and SMV, and lipolysis trigger inflammatory response like fat necrosis, leading to symptom in the joint and adjacent periarticular tissue, and like leading to arthritis and panniculitis. You are really smart. I'm really amazed by you.
Yeah, Hima, I really appreciate how I think Prof. Rez saw these nodules, translated them into erythema nodosum, and then told us why they probably weren't erythema nodosum classically based on the location that they were present. And I think that when you do that, you start to say this is panniculitis, and that was one avenue. The other avenue I think that this case really reflected is just how specific of an entity oligoarthritis is. After you exclude infection, which was really important to do, oligoarthritis is often either crystalline or spondyloarthropathy. And I think your outstanding exam that made uveitis and back issues really helped us get closer and closer to crystalline disease. And I think this case really is a reminder that there are so many kinds of crystals that can happen, that can affect us: gout, pseudogout, basic calcium phosphate, fluoride, oxalate, and then fat crystals. And God, I'm glad it wasn't pancreatic cancer that was the trigger for this, but really, really a lot of rich learning along the way. So thank you so much for bringing this case, and also just strategically presenting the key data along the way. It was really educational. Prof. Rez, what are your thoughts?
Yeah, thank you, Himoon, for presenting this case. I thought it was extraordinary, and I don't think the main takeaway for this case is the final diagnosis. Like, if you leave this thinking that you know, this final diagnosis is going to make you, it won't make you a complete doctor. It's how do you think through a case like this? And how do you search properly to arrive at the right diagnosis? So if I were to go back and reflect on this case, I would try to create an approach for joint pain. I would try to create an approach for E nodosum, and then I would see how I can overlap the two way before I would study the illness script for the triple P. But thank you for presenting it. I mean, rare stuff do happen, and it's great to include that into our, possible diagnoses. Thank you, Himun. I'm going to give the mic to Amol.
What a great case. Thank you so much, Himun, and the amazing discussion. And I'll start with the teaching points. So initially we had a patient presenting with joint pain, and we realized that when we have a joint pain, it's not necessarily that joints are involved or they have a problem inside. It could be a diffuse tendon, ligament, or bursal problems. But if more joints are involved, we think that there's a high probability of the involvement of joints. And then we classify it into 3 types: monoarthropathy, oligoarthropathy, and polyarthropathy based on the number of joints involved. Monoarthropathy has mostly the causes of crystalline causes. Polyarthropathy is almost always autoimmune, exceptions like viral infections and chikungunya. But oligoarthropathy is common for both monoarthropathy and polyarthropathy. It includes crystalline and autoimmune. On autoimmune, we have spondyloarthropathy, which has ankylosing spondylitis, IBD, psoriatic, and 3 of them. And then we saw that the patient also had rash. So we discussed that morphology is the key when we have to evaluate a rash. And the patient had painful red bumps on the leg, which raises concerns for erythema nodosum, which is a kind of a hypersensitivity reaction. Or we could think of its differential. So it was important to note the medicine history, especially antibiotics. And the other differential we had were erythema induratum, which are painful ulcerative lesions secondary to TB. And the third one, leukemia cutis, secondary to leukemia, or insect bite or trauma. So all the differentials were coming to our mind. And then we thought that when we see a palpable purpura on lower extremity, we don't really biopsy it because mostly it comes out to be leukocytoclastic vasculitis. So it doesn't really change the differential. And similarly with erythema nodosum, it usually shows paniculitis on biopsy, so we don't biopsy it. But the conditions in which we biopsy it are if the site involved is other than leg, or there is associated ulceration, or the rash persists more than a week. And this case was coming out to be of a case of oligoarthritis. So we thought we ruled out causes like infection, and the other causes, and crystalline was coming to the forefront. And we were thinking about gout, which can cause paniculitis as well. So therefore, we were mainly concerned with the crystalline causes. And then we also thought about Lofgren syndrome because we were suspecting sarcoidosis. And Lofgren is basically a specific acute clinical presentation of systemic sarcoidosis. Therefore, we also thought that chest X-ray could help to look out for hilar adenopathy. And then ultimately, we just thought what could cause crystals in the synovial fluid. We were mainly thinking about the main causes, gout and CPPD, but there are some other causes like PPP, which is pancreatitis, paniculitis, and polyarthritis. It is just another cause of synovial crystals, and it is mostly secondary to alcohol abuse, and serum lipase test will help in this case. And we also studied that yellow synovial fluid is very unusual. So we have to evaluate that. And the mechanism behind it is that lipase breaks down fat to cause paniculitis. And there's also a lot of adipose tissue surrounding the joints, which is destroyed by the lipase, causing the yellow synovial fluid, and it destroys the joints as well. So we thought that imaging the pancreas would help. And ultimately, the patient was diagnosed with the PPP syndrome with the evidence of pancreatitis, paniculitis, and polyarthritis, all of the 3. Thank you so much for the case.
Wow, well, that was such a great recap of the whole case, the journey, and the learning along the way. Absolutely superb. It's like you were able to synthesize it into a very linear story. Thank you so much. Himun, that was a really, really memorable case. Really appreciate you taking the time to put it together and to install the key aspects every single way. The paniculitis and arthritis in Alquat 1, the alcohol history in Alquat 2, the really rich exam in Alquat 3, and then the really cool clues at the end. It was a real treat. Thank you. All right, well, enjoy the rest of your Friday. Bye.